Welcome back. You're watching McLaren Port Huron's Today's Health, and we're talking about breast health imaging services. And in this segment, we're going to be talking with board-certified radiologist Dr. Edward Mauch. Dr. Mauch, welcome to Today's Health.
Thank you for having me today.
Can you just kind of give us a list of all of the different technologies you use for screening and diagnosis?
Sure. The main modality we use for screening is your typical mammogram, which all women beginning at 40 years of age are used to having done. From the mammogram, we can advance to other modalities. Ultrasound is a common used thing to work out abnormalities we see on the mammogram. MRI is another modality which has taken off over the last few years, which we can utilize when there's an issue rises on the mammogram.
How do you decide with all the different technologies what image that the woman needs for breast diagnosis?
Well, in mammograms or in women's imaging, it's a team decision between the patient seeing their primary care doctor, whether that's a family doctor, internist, or OB/GYN, or even a surgeon sometimes, when the patient presents with something, or if it's just their annual mammogram or annual workup, they help decide, and working with the radiologist, when we have the patient in the Women's Wellness Center, we are able to, based on what we see on their mammogram, we can decide if they need further imaging, if with more mammogram pictures, or if they need ultrasound or MRI sometimes.
And all of these imaging technologies require a physician order, is that correct?
Yes, ma'am.
So if a woman is a little confused, I mean, basically it's something that the physician initially orders the test.
Yeah, the physician, they'll go see their physician, and the physician will determine what they think is the best, and the radiologist, we answer a lot of phone calls from them, and we'll help guide them, or even change their order when the patient shows up to guide the appropriate workup we think the patient will need.
Well, let's start with mammography then, which is very common, and most women, like you said, over 40 are acquainted with. Tell me all about it.
Yeah, so mammography, all women are encouraged to do monthly breast exams, and they have their clinician do a yearly exam. Beginning at age 40, the ACR recommends that all women come in for an annual mammogram, which we do 2 views of both breasts. We're very excited. We just started a new technology called 3D mammogram or tomosynthesis at the hospital here, which should help us do a better job at detecting cancers in the female population in the community.
Well, all of us women, we always want the best. So is 3D appropriate for every woman?
3D is, initially we're going to market mostly for diagnostic workups, high-risk patients, women with denser tissue, which has become the hot thing. Women have started to notice they get more letters now if they have denser tissue. That's what we're primary targeting, but we see that the 3D will likely benefit all women in the community, and we're hoping down the line, in fact, a lot of the breast experts around the country think the 3D technology over the next 10, 20 years will take over the digital mammogram or the 2D mammogram.
Why are women sometimes called back for additional views after a mammogram?
Very good questions. The mammogram is a screening study, so we want to be very careful. We want to make sure we don't miss any cancers, and I know it puts a lot of stress under women to have to come back for additional workup. But the radiologist sees something that they just aren't certain about, and they want to do additional workup. So typically we'll do additional views where the woman will come in for different pictures, different mammogram pictures. And if it's still suspicious, we usually will do an ultrasound, and that's all done the same day. And the ultrasound, between the mammogram and the ultrasound, usually the radiologist is able to make a decision of what management needs to be done.
So that was my next question about ultrasound. That's kind of a second-line test in determining what's what?
Yeah, ultrasound is a second-line test for helping us figure out if something on the mammogram is really something abnormal, or it could just be normal tissue mimicking something abnormal. We do use ultrasound primarily for women under 40 and for sure women under 30 because there's no radiation, and typically the younger women have very dense tissue, so the mammogram is of less benefit. So ultrasound, especially when they come in with palpable abnormalities, will be our first line choice for younger women.
Now, MRI is something we haven't talked about a lot in terms of breast imaging. Tell me about that.
MRI has become the newer technology over the last 10, 15 years. Primarily, it's used for higher risk women. You've heard about the BRCA gene, people that have a significant high chance of developing breast cancer. A lot of those women will have to, we recommend trying to get annual MRIs to monitor. Another common thing it's used for is if we find a patient with cancer, we'll periodically image them with the MRI to make sure there's not a second cancer hiding out in that breast or another cancer in the opposite breast, which would change their management. When we do the MRI, we always image both breasts and do a full workup for both breasts and the axillary regions.
And then obviously at some point some women end up with a breast biopsy. When is that?
So if we find a lesion that still is suspicious on the mammogram or on the ultrasound, or even once in a while on the MRI where we can't find a corresponding lesion on the mammogram or ultrasound, we can offer biopsy via all those techniques, either using the mammogram, the ultrasound, or the MRI guidance.
So tell me a little bit more about that. So when you do a biopsy like a stereotactic or MRI guided, how does that work?
Yeah, the stereotactic guided core biopsy is basically using the mammogram, and then you have the ultrasound and MRI guided biopsy. And basically, we'll tell the patient that there's a suspicious lesion. We usually refer them to a surgeon who they can discuss their results and tell them, or basically usually tell them this is what they can expect. And the stereotactic guided core biopsy, a lot of the surgeons or the radiologists will do it in the hospital, in the women's center outpatient, or in the ultrasound and the MRI guided biopsy, the radiologists do it, and we bring the patient back another day. We show them, give them education on what they can expect. It's depending on the modality we use, it's pretty similar. We do sterile technique. We anesthetize the skin and tissue, and then we use a biopsy device to take some tissue for the pathologist or the microscope doctor to give us a tissue analysis of this area that we're concerned about.
Well, you've made things a lot clearer about the different sequencing and what tests might be used. Do you have any closing comments for our viewers?
The main thing is it's very exciting that we're adding this tomosynthesis in the hospital. We're going to be this is the only hospital in St. Clair County that will have the 3D mammogram imaging, and this, like I said, should significantly help because it should bring back down, it's better accuracy in helping us find cancers in women, and also should diminish our callback rates for women that have to come back for additional imaging using this new technology. A 3D picture versus a 2D picture will bring down our callback rates as we're expecting as it's done around the country, and help us do a better job than we're doing now, even though we're doing a good job.
Thank you so much for joining us.
Thank you.
Stay with us and we'll be right back.